the UK, between 55 and 60,000 patients are now diagnosed each year with early breast cancer. And that figure has been increasing decade by decade over the last 30 years.
Looking at the incidence and the frequency of breast cancer diagnosis, it remains a major healthcare challenge, and therefore there's a continued need to improve our diagnostics, but also our treatment options for patients with breast cancer.
Research needs to continue to understand the unanswered questions where we can refine treatment plans. Trials take time to introduce new therapies, but if we look back over the last 20 years, the new treatments have produced better cure rates now in each individual subtype, and progress is continuing at a steady pace. Individual trials can tell us about the benefit of very, very specific targeted treatment. However, the ability to give optimal treatment is often now an understanding and a consensus about what the standard way of treating patients is. And this is more about integrating, for example, chemotherapy that's been around for 20, 30, 40 years, and optimizing the use of that and the optimal duration of, say, hormone-based treatments.
There are 2 phase 3 studies of immune therapy in early triple-negative breast cancer at this point in time. Both of them used immune therapy in combination with preoperative chemotherapy, and there was a larger trial called KEYNOTE-522 that has 2 primary endpoints to see whether immune therapy adds benefit in this setting. A short-term endpoint, which looks at what we call the pathological complete response rate, so the disappearance of the cancer at the end of the treatment, which is linked with long-term outcome, and a long-term endpoint, which looks at recurrences. There's a second study in PASSION-031, which is much smaller. It's about a quarter of the size of KEYNOTE-522. And because it's smaller, it really only focused on path-CR rates on the short-term endpoint. Both trials show, actually consistently, that the addition of immune therapy to preoperative chemotherapy substantially, and in my opinion, in a clinically meaningful way, increases the path-CR rate, the rate of disappearance of the cancer at the time of surgery. In KEYNOTE-522, the trial that was powered to look at long-term outcome, we've also seen a 37% reduction in the risk of recurrences, a 39% reduction in the risk of distant recurrences, which is obviously the most important endpoint, because with distant recurrence not being able to be treated in a curative way, this is expected to translate into survival benefit over time.
Other therapies will undoubtedly come through from advanced breast cancer into early breast cancer. And one of the big developments is about mutations in tumors, understanding key mutations for which there are other targeted drugs, PI3 kinase inhibitors, AKT inhibitors. These are being used in metastatic disease. We don't know if they'll have a role in early breast cancer. And the other thing that we're researching very heavily is ways of monitoring patients and picking up cancer recurrences early, using tiny fragments of DNA in the blood, so circulating tumor DNA, to see if we can pick up early signs of molecular relapse, cancer that's still in the bloodstream but not evident on scans, and eradicate that with additional treatments. So these are challenging studies to do. The technology is improving all of the time, but we're now looking really at trying to find tiny fragments of cancer and see if we can eradicate it in high-risk early stage disease. But these are some way off from becoming clinical practice.
My biggest hope in this context is the introduction of antibody-drug conjugates, which have shown substantial activity in metastatic breast cancer. If you look at the activity of some of those agents with a 7 times higher response rate compared to standard chemotherapy in a metastatic setting, with a 3 times longer progression-free survival and doubling of overall survival, what impresses me in particular is the high response rates, because that's what we need when we have residual disease, to get rid of those residual clones. We've also seen very encouraging signs in metastatic triple-negative breast cancer from the combination of antibody-drug conjugates and immune therapy, where there's suggestion of a high synergistic activity. We've seen data in a first-line triple-negative breast cancer setting, combinations of antibody-drug conjugates with immune therapy resulting in a response rate of around 80%. Now, if you think about transferring that activity into a high-risk early disease setting in patients with residual disease. My hope is very clear that we will be able to cure more patients, and I think that's where the biggest need is at the moment.
So as new therapies become approved based on individual trials, it will be really important to see as they're integrated into clinical practice that we find in individual countries if these treatments are actually making the results of how they manage breast cancer better over the next 5-10 years. And this takes time to accumulate because it's not an instant feedback.
Despite all the progress we have made over the last few years, there's no room for being complacent because unfortunately, we still can't cure every patient.
So in terms of understanding where our research needs to continue to progress, the biology of why those cancer cells are resistant to those treatments and what drives that risk of recurrence is still something we need to continue to work on.